Most people believe that if a doctor writes a prescription, it must be safe. The pharmacy fills it. The bottle has clear instructions. Take one daily with food. Just swallow and trust the process. I used to believe that too, until I started reviewing medication lists for a living, reviewing the lists of patients who came in steady on their feet and left in a wheelchair. Not because they got sicker, because of what was sitting in their medicine cabinet. A woman who took the same sleep aid for 15 years and one night couldn't remember how she got to the bathroom floor. A man whose safe, over-the-counter pain reliever quietly shut down half his kidney function before anyone noticed. Here's what nobody tells you at the pharmacy counter. The older your body is, the less forgiving it becomes of the exact same pill you've taken for years. Not because the medication changed, because you did. My name is Dr. Elena Marsh. I'm a physician specializing in geriatric medicine and medication safety, with over 20 years treating older adults. And today I'm going to tell you the truth about 5 common medications that carry serious hidden risks after age 60. Let me ask you something. If you pour the exact same amount of water through a wide open pipe and then through a pipe that's narrowed and partly clogged, do you expect the same flow? Of course not. And yet for decades, medicine dosed a 75-year-old the same way it dosed a 45-year-old. Same starting dose, same refill schedule, same assumptions. That's starting to change, but not fast enough. Here's what happens inside an aging body when a pill gets absorbed. The liver breaks medication down more slowly. The kidneys take longer to clear it. Body fat increases and muscle decreases, changing how certain drugs get stored and released. And the brain? This is the one that catches families off guard, becomes far more sensitive to anything that touches the nervous system. Doctors have a term for it, altered pharmacokinetics. And in patients over 70, it means a normal dose can behave like a much larger one. Now, I want to be absolutely clear about something. Taking medication is not the problem. I have patients in their 80s managing 5 prescriptions beautifully. The number of pills is not the danger. The mismatch is. A mismatch between the dose, the drug, and the body actually taking it. Roughly 1 in 3 adults over 65 in the US takes 5 or more medications regularly. Once you cross that threshold, the odds of a harmful interaction rise sharply with every medication added. So here's the real question. It's not whether a medication works. It's whether your body today, right now, can safely process it the way it did 10 years ago. Those are 2 very different things, and that distinction is going to matter a great deal right now. Medication 1, Benzodiazepines. Drugs like the common anti-anxiety and sleep prescriptions many people have taken for decades. The idea is simple. Anxiety keeps you up, or your mind won't shut off. The pill calms the nervous system down, and for short-term use, it can genuinely help. But here's what the label doesn't make obvious. These medications slow reaction time and impair balance, and older brains clear them far more slowly than younger ones. For a 55-year-old, that grogginess fades by morning. For a 78-year-old, it can still be affecting coordination the next afternoon. Research in geriatric medicine consistently links long-term benzodiazepine use in older adults to a higher risk of falls, hip fractures, and next-day cognitive fog, often mistaken for early dementia. And here's something that stops families cold. A serious fall from one of these medications can be the single event that ends someone's independence for good. So what's the alternative? In many cases, there is one. It's called cognitive behavioral therapy for insomnia, a structured, non-drug approach that outperforms sleeping pills in long-term studies without the fall risk. Does this mean you should stop a benzodiazepine on your own? Absolutely not. Stopping suddenly can be dangerous. It means you should ask your prescriber one question. Is there a plan to taper me down safely? That question alone could change everything. Medication 2, everyday NSAIDs. Ibuprofen, naproxen, the pain reliever sitting in nearly every medicine cabinet in the country. Joint pain in your 60s and 70s is almost universal. I don't know a single patient over 70 who hasn't reached for one of these. And the habit that forms is completely understandable. Take it daily. It works. Keep taking it. Now, I need you to hear this clearly. Occasional NSAID use for an isolated headache or ache is not what concerns me. But daily, ongoing use in an older adult, the evidence is genuinely troubling. These medications reduce blood flow to the kidneys and can raise blood pressure even in people who never had hypertension before. A well-known review of kidney injury in older adults found regular NSAID use among the most common preventable causes of sudden kidney decline after 65. The most common warning signs weren't dramatic. Swelling in the ankles, creeping blood pressure numbers, and blood work that quietly worsens visit after visit until a doctor finally notices. And here's what frustrates me most for many patients: the pain relief. Studies on chronic joint pain show that for a lot of older adults, acetaminophen combined with physical therapy and topical treatments provides comparable relief with dramatically lower organ risk. Not always, but often enough that it deserves a real conversation. I had a colleague, a nephrologist, who once told me, "Elena, half my new dialysis referrals are people who thought a drugstore pain pill couldn't possibly hurt them." I think about that a lot. Have you ever taken an over-the-counter pain reliever every single day without telling your doctor? Write that in the comments. I want to know how many of you have done exactly that. Medication 3, anticholinergic drugs. This one is the hardest to talk about because these medications hide in plain sight. Older allergy pills, certain bladder control medications, some over-the-counter sleep aids. And when someone hears, "It's just for allergies" or "It's just to stop bathroom trips," the instinct is to dismiss the risk entirely, and I understand that completely. I'd feel the same way. But here's what 2 decades in this field has taught me. The goal of any medication is not just to treat one symptom. The goal is to protect the whole person, including the brain, for years to come. And sometimes, not always, but sometimes, a medication that quiets one symptom quietly does damage somewhere else. Let me give you a real example. Long-term, cumulative use of strong anticholinergic drugs is one of the most studied and debated topics in aging research today. In lower-risk patients, occasional use is unlikely to cause lasting harm. In a 79-year-old already managing several other medications with anticholinergic effects stacked on top of each other, the cumulative burden has been associated in multiple large studies with a measurably higher risk of cognitive decline over time. This is sometimes called the anticholinergic burden, and it's more common than anyone admits because these drugs stack quietly, one for allergies, one for sleep, one for bladder control. A large body of research tracking older adults over many years found that higher cumulative exposure was associated with meaningfully increased dementia risk, meaning the damage isn't always from one drug, it's from the pile. So what's the conversation worth having? Ask your pharmacist this question directly. Can you calculate my total anticholinergic burden across everything I'm currently taking? That question opens a door many patients never even knew existed. And sometimes the answer behind that door is genuinely reassuring. Medication 4, opioid pain relievers. Prescribed after surgery, for chronic back pain, for severe arthritis flares. These medications are among the most effective tools we have for real, severe pain, and for the right patient, they restore quality of life in a way nothing else can. But here is where it gets complicated for older adults. The word effective doesn't mean risk-free. You have a body that clears opioids more slowly, breathes a little shallower at rest, and balances less steadily than it used to. And crucially, a body that reacts differently when this medication is combined with something as ordinary as a glass of wine or another prescription. Because here's what the statistics show. In patients over 70, opioid use significantly increases fall risk, and when combined with sedatives or sleep medications, the risk of dangerous slowed breathing rises sharply. Add reduced kidney clearance, and the picture becomes much more complex. I want to be precise here because I don't want to frighten anyone away from pain relief that they genuinely need. The question is not, should I ever take an opioid? The question is this the lowest effective dose for the shortest necessary time, with everything else on my medication list accounted for? Some clinics now require a full medication reconciliation, a line-by-line review of everything you take, before prescribing an opioid to a high-risk older patient, and that's exactly the right approach. Has your pharmacist ever sat down and reviewed every medication you take, all at once, in one conversation? Most people have never experienced that, and they absolutely should. Medication 5, the Polypharmacy tipping point, 5 or more prescriptions taken together. This one is different from the others. No single medication on this list is usually the villain. It's the stack. A new prescription here, a refill there, a supplement nobody mentioned at the last appointment. These situations build slowly. They don't announce themselves. But here's why it belongs on this list. Knowing the danger zone in advance, before a bad interaction happens, changes how families make decisions during a hospital stay or a new diagnosis. Older adults on 5 or more medications face substantially higher rates of dangerous drug interactions, emergency room visits, and hospitalizations than those on fewer, not because any single drug is unsafe, but because a body juggling that many chemical signals at once is fighting on too many fronts. The liver, the kidneys, the nervous system, they're all processing simultaneously. And a new medication that seems harmless on its own can tip an already stacked system into something doctors call a cascade. One drug side effect gets mistaken for a new illness, which gets treated with another drug, which causes its own side effect. When that cycle starts, it is as serious as it sounds. So what can you actually do with this information? 2 things. First, do not assume every prescriber can see your full list. Bring every bottle, including supplements and over-the-counter drugs, to every appointment. Catching an unnecessary medication early means removing it before it causes harm. That one habit can change everything. Second, ask for a full review at least once a year, not just when something goes wrong. What is every one of these medications actually doing right now? Does the reason I started it still apply? These conversations are not a burden on your doctor's time. They are one of the most protective things you can do for your own independence. All right. We've covered 5 medications. Now let's talk about what you actually do with this knowledge, because information without action is just anxiety, and that's the last thing I want for you. Before continuing or starting any medication, there are 4 questions every patient over 60 should ask. Write these down. Question 1, what happens if I take a lower dose, or wait, before adding this? A good prescriber will give you an honest answer. If the answer is nothing urgent, changes in the next few weeks, you have time to think, time to get a pharmacist's opinion, time to try a non-drug approach first. Question 2, is there a safer alternative for someone my age? Medicine has changed enormously in the last 15 years. Non-drug therapies, lower-risk drug classes, extended-release formulas that were designed with older adults in mind, options that didn't exist a decade ago are now available at most pharmacies. Question 3, what does this look like specifically for my kidneys, my liver, and everything else I'm already taking? Not the average patient, you. Your blood work, your other prescriptions, your living situation. The answer should be specific, not generic. And question 4, this is the one most people never ask. What is this medication's real risk profile in patients over 70? And is there a plan to reassess it in 6 months? Pharmacists track this. They know the interaction data. A confident, honest prescriber will walk you through it. If they seem uncomfortable with the question, that itself is information worth having. Before I get to the most important part of today, I want to leave you with something genuinely hopeful. Because this is not a video about fear. It's about options. And those options have never been more available than they are right now. Medication reconciliation programs have transformed what's possible for older adults juggling long prescription lists. Pharmacist-led reviews, deprescribing clinics, and apps that flag dangerous interactions before a prescription is even filled are now available at most major pharmacy chains. And beyond medication itself, and this is something I wish more patients heard, non-drug management is genuinely powerful. The right combination of physical therapy, sleep hygiene coaching, dietary adjustment, and community support can manage many symptoms that previously seemed to require a pill. The body wants balance. Sometimes our job as physicians is simply to remove what's throwing it off and give it room to find that balance again. I want to tell you about a patient. I call her Ruth, 74 years old, retired school teacher, sharp as a tack. She came to me after 3 different pharmacy refill notices piled up on her kitchen counter, 7 medications total, several started years apart by different doctors who'd never spoken to each other. Ruth wasn't afraid of her pills. She was afraid of what she'd become. Her daughter had watched her get quieter every year, foggier, unsteady on the stairs, and everyone assumed it was just age. She told me, "Dr. Marsh, I used to do the crossword every morning. Now I can't finish a sentence by dinner." That sentence has stayed with me ever since. When I reviewed Ruth's full list, 3 medications stood out as unnecessary or duplicative. One a sleep aid she'd been on so long, nobody remembered why it started. I sat down with her for 40 minutes, not 15, 40, and I told her the truth. We could taper 2 medications carefully and switch a third for a safer alternative, slowly, with monitoring. The data for her specific profile showed she was carrying real risk with very little added benefit. She agreed to the plan. That was 3 years ago. Last month, she sent me a photograph. She's sitting at her kitchen table finishing the Sunday crossword before noon, pen in hand, grinning like she'd solved something bigger than the puzzle. Here's what I need you to understand. This is the single most important thing I will say today. A prescription is not a life sentence. It is the beginning of a conversation that should keep happening. You are not a passive recipient of whatever gets refilled automatically. You are an active participant in your own care. The moment you sit down with a doctor or pharmacist, you have the right to ask every hard question, to request every alternative, and to take every appointment you need to get it right. The prescriber holds the pen, but you hold the choice. And that choice, made with full information and clear eyes, is the most powerful tool in medicine, more powerful than any pill I've ever prescribed. Let's bring it all together. 5 medications that carry serious hidden risks for people over 60. Benzodiazepines, where a safer non-drug path now exists for most patients. Everyday NSAIDs, where the kidney risk is far higher than most people are told. Anticholinergic drugs, where the danger comes from the pile, not any single pill. Opioid pain relievers, where dose and combination matter as much as the medication itself. And the polypharmacy tipping point, where the best protection is a full review and an honest conversation with your family and your care team. Now, none of this means stop your medications. Medication saves lives and preserves independence every single day. I have seen it. I have been part of it. I am proud of it. The message is this: be an informed patient. Ask the hard questions. Request the alternatives. Get a second opinion from a pharmacist, if not a second doctor. Your age is not a weakness. What question would you most want to ask your pharmacist before your next refill? Tell me in the comments. I read every single one. And if this video helped you or someone you love take a closer look at what's in that medicine cabinet, share it. That one share might be the most important thing you do today. Take care of yourselves. Stay curious. Keep advocating for your own health. You deserve a prescriber who explains everything and a care team that treats you as a partner. And one last thing, everything I've shared today is general medical information based on published research and clinical experience. Every person's situation is unique. Before making any change to your medications, please have a full, honest conversation with your own doctor or pharmacist. They know your history. They know your body. And that conversation, informed, direct, and unhurried, is exactly where good medicine begins.